Hello everyone, this is the continuation of the urinary tract infection, and let's go through the statistic now. And it shows the right side, the compromised version of the study results, and it shows the amount of the chances of the bacterial growth in men and women in the community more than 70 years, which is more relevant, and the chances of finding the pathogens, bacteria, and the patients who have a catheter for long term is about 100%, in the short term 3 to 5%, but it doesn't mean that if you find a pathogen that you have the patient with the urinary tract infection, you just don't have to therapy based on the pathogen which is found in the culture. The therapy is based on the clinical symptoms of the patient, the actual clinical condition of the patient. Based on that should be taken the indication of the culture, and the therapy should be based on the actual condition of the patient. Now you always have a chance to have some pathogen in the culture if you have a patient who has a catheter in the long term. So the random use of antibiotics is not recommended. But there is some cases where you have to think about the antibiotic therapy if you have a culture pathogen positive in your urine culture. They are the patients who have recently had the kidney transplantation, who are under immunosuppressive, and if you have positive urine culture, then you have to begin the therapy with the antibiotics. The key message here is that urine culture should not be taken as a screening for antibiotic therapy. It should be based on clinic of the patient. If the patient has fever, if the patient says, I have pain when I'm urinating, then dysuria. These are the conditions where you have to go look for the urine culture and see if you have leukocytes in urine, and based on that you have to begin the therapy. So the most important thing is the patient's history. If the patient is saying, I have pain urinating, some women, they also have vaginal symptoms, then do they use sticks and begin the therapy based on what kind of patient you have. In this case, sometimes the quantification of the urine, like how many leukocytes are there, they're also helpful. In case of urine sticks, we just go like 1 plus, 2 plus, and 3 plus. It doesn't clearly say how much leukocytes you have. And for example, for 3 plus, what we have in use sticks, it is around like 249 to 770 around leukocytes. It does not clearly say that you have a urinary infection, so you can also look for the number of the leukocytes in urine. So to summarize, to diagnose a urinary infection, you just go based on the symptoms like dysuria or fever, if there is hematuria or suprapubic pain, how much frequency I have to go so often to the toilet, and means it just suggests you, and sometimes something which is new by the patient, like newly the patient, they cannot control their urine, it is also a sign of urinary tract infection. Then you just go for the urine culture and begin the antibiotics. So it should be based on the clinical symptoms of the patient to diagnose the urinary tract infection. So there are also two dynamics. There's uncomplicated urinary tract infection and the complicated. If the patients, they have high risk to go to the urosepsis, or if they have comorbidity, other diseases like diabetes, old age, and also anomaly in the urinary tract infection, which is urinary tract, which is already known. They are the risk for the patients to develop sepsis. So they are they fall in the group of complicated urinary tract infections, and the other, which is normal patients, young patients, which does not have so many diseases, they just belong to the low risk patients, and they are defined as the uncomplicated urinary tract infections. And to get the correct urinary culture, it's important to take the midstream, which also midstream urine. In this statistic, you can see that the correlation of the catheterization of the patients and the how it relates with the number of the growth of the E. coli. In case of enterococcus, it does not have any correlation. It means that if you have enterococcus positive in urine, then it is normally not the cause of the urinary tract infection. In that case, you can take the sample again. And here is the guideline based antibiotic therapy for the patients who have uncomplicated urinary tract infection. And normally we just give fosfomycin or penicillin. And based on the study for fosfomycin, the therapy can be given often on the first day, third day, and the sixth day, which also showed a very good result for the patients for the ambulant therapy of the urinary tract infection. And there is a recommendation for the pyelonephritis. It is, in case of pyelonephritis, sometimes difficult to differentiate if the patient has the middle or the high grade of pyelonephritis. So sometimes, if the condition is bad, then it is recommended to give the antibiotics through the vein, and in time, in 2-3 days, you can just change the antibiotics, oralize the antibiotics based on the clinic of the patient's symptoms. If they are better, then you can oralize. And if you have the condition of the pyelonephritis, what is important is that you just take urine culture and even the blood culture, so that you can find the bacteria in the blood, and based on that you can change the therapy if you have resistant to the antibiotics which you just begun, and if the patient has fever, even although you have antibiotics already started. And to add on this, if you have mild symptoms, mild infections, then you can even oralize the antibiotics. But if you have the severe pyelonephritis, then you just begin intravenous therapy. In case of therapy begin, we should consider the resistance also. Mostly quinolones have more resistance than the cephalosporins. So cephalosporins are recommended based on the guidelines. And if you don't have any culture at the time, just begin with the bright spectrum antibiotics, calculated antibiotics like piperacillin, tazobactam, or ceftriaxone, which we normally do with ceftriaxone. In case we can escalate or de-escalate based on the symptoms of the patient and the antibiogram.